Good afternoon, good morning, good evening, everyone. Great to see you all. Happy Wednesday. Hard to believe we're almost halfway through October. I feel like most VMRs I'm saying it's hard to believe it's this point in time, but here we are. We are excited to be here today. Zavin is going to pop back in soon. And Travis has a case he's going to share with us. So we're looking for two discussants to join us. So please give us a shout out if you're interested in discussing. And we heard just recently that, yeah, Franco has a human DX case that was published today. So definitely check that out if you haven't seen it already.
I'm going to link the case in the chat for everybody. So if they want to solve it afterwards.
Great idea. Just waiting to hit our threshold of Zoom silence and thus activation.
Yes. We need that Jeopardy music.
Or a separate new jingle. What do you think? I guess
Anybody?
Jeopardy is.
Was it Kara who came up with the RLR jingle? Kara Lau? Am I making that up? I think it was. We need her to write a CPS discussant volunteer jingle.
Thank you, Sharada. Good. Everyone's got a different awkwardness threshold, so glad we hit yours first. Do you want to unmute and just say hi to the group and let us know what you're up to these days?
Yeah. Hi, my name is Sharada. I am a fourth year med student at UCSF. I'm currently on a leave of absence, so I'm just popping in, enjoying learning opportunities where I can now that I have some more leisure time. And yeah, that's about it.
Awesome. Welcome. We're really excited that you're here now. And it looks like Abdulaziz is also interested in joining. Do you want to say hi to the group and introduce yourself also?
Hi, everyone. My name is Abdulaziz. I am from Somalia. Graduate from Sudan and finished my internal medicine rotation in Sudan. Hi, everyone.
Thank you for joining. All right, so we will have Travis share his case, and how do you want to pair up and do things?
Doesn't matter. I think Abdulaziz, I think I paired up with you one time. So maybe Steph can pair up with you. Great. And I can be with Strada.
Great.
This okay, great.
Awesome. Well, I found some Jeopardy music that I'll have on hand for next time. You guys hear it?
Yes, perfect.
All right, so for next time. So we'll start with a case, a human DX case, and the chief complaint, it is a 50-year-old female presenting with fatigue for 2 weeks. So that is the first aliquot.
Shraddha, why don't we start, and how do you approach the symptom of fatigue in a middle-aged lady?
Good question. Exactly the question that I was asking in my head. So I think my first my first thought is that fatigue is such a broad and general word, and I think that it's one that patients can often use in a different way than we interpret it. So fatigue is, so I would ask to myself, is this really fatigue? Could this be like a general sense of malaise or asthenia? Could it be more of an actual like neurological weakness? And so in order to sort of suss that out, I would want to know, well, first of all, we know that this is subacute, so that is really helpful. But I would want to know if there are any associated symptoms. Thinking about, could this be something, if it's more focal weakness, then I would be very worried about something neurological. If it were sort of more general malaise or lack of energy, then you could think about, could this be inflammatory? And then sort of under the bucket of inflammatory, you could think about some sort of subacute infection or like an autoimmune rheumatologic cause or malignancy. Those can all sort of be under that broad inflammatory category in my brain. And then I think also in this person, I wouldn't want to miss the possibility that something psychiatric could be going on, like depression or anxiety. And so as I get more of the story, I would also want to keep that in mind. But those are sort of the first things that pop up in my brain. I would definitely want more information.
That was amazing. Great kind of big picture approach. The one category of symptom that people also describe as fatigue is also shortness of breath, like sort of cardiopulmonary insufficiency, right? Like fatigue when they try to move. Yeah, otherwise couldn't have said it better myself, Shraddha. I don't have much more to add. Let me ask you this. What if this was a USMLE world question? 50-year-old woman, main symptom is fatigue. What's the diagnosis?
Because that's how we practice.
Because that's how we practice medicine.
Oh man. I mean, my problem is that I have like now too many options in my brain, and now I'm thinking like now there's all sorts of stuff coming in the chat. Maybe it could be endocrine as well. I forgot to mention, I always forget about the thyroid, but that would actually be my guess.
You know, but the right answer I think was like, you can't ask me that, right? Like, I think that's the right answer. The reason I think one diagnosis popped into my head, which was primary biliary cirrhosis, which is that the two most common presenting symptoms of that condition are fatigue and pruritus. And the reason that association is so strong is because, you know, in that condition, oftentimes, like all the other kind of causes of fatigue, you know, sort of don't seem to pan out. And the fatigue is just so prominent. Those patients will just be like, I feel like I have to go pee. I really have to go pee, but it's just like, it's like a ton of bricks is on my shoulders. And like, it's just such an effort to even just move. So I use that example just to emphasize just how, while it's such a non-specific symptom, it can be a really debilitating one and really sort of a hard to explain pathophysiologically manifestation of like a, you know, systemic or localizing syndrome. Let's hear more.
You got it. All right. So, a patient presented to the emergency department with 2 weeks of worsening fatigue and malaise, as well as a little bit of intermittent epigastric pain. She denies nausea, vomiting, fever, chest pain, shortness of breath, night sweats or fever, denies any recent travel. She was recently hospitalized and treated 3 months prior for TTP that was provoked by nitrofurantoin. She required several plex therapies with high-dose steroids and rituximab, because rituximab fixes everything. At her most recent follow-up, there were no signs of continued hemolysis and her steroids were weaned. She's been on atovaquone for PCP prophylaxis. And how do you print? Is it atovaquone or atovaquone? Does anyone have
I
any
say
insight?
atovaquone.
Atovaquone. Perfect. Thank you. Past medical history. She has TTP, like I mentioned, that she received nitrofurantoin for a UTI. She has hypercholesterolemia, history of Graves' disease, status post partial thyroidectomy, and paroxysmal AFib. Her meds, she's currently on she was just on a pred taper, 20 milligrams, atovaquone, cetirizine, atorvastatin, apixaban, levothyroxine, cholecalciferol, and denies any other herbal or dietary supplements. Social history, she drinks occasionally, denies drug use, and she is married. So that's the end of the next aliquot.
Thanks, Travis. What do you think, Abdulaziz? Share your thoughts.
Okay, the case from get complicated. So from the history of fatigue, and the history of TTP and receipt of steroid and immunosuppressive drug. So I put my differential this ability to reactivation or chronic infection that give the patient fatigability. So from the epigastric pain, the most common is the patient reactivation of hepatitis B, or the patient have reactivation or cholangitis. So the most, I think the patient, I think about the chronic infection. The other thing I think about that is this the patient have again TTP or developed anemia, so the patient have fatigability again. So this is my mind. We play with chronic infection that patient have fatigability, but what is going against the chronic infection, the patient have not fever, no night sweat, not. So I think this maybe is recurrent anemia. So this is my mind now.
Thanks, Abdulaziz. That was great and really hit a lot of important points. The first being, yes, the case got a lot more complicated when we heard her recent medical history. I'll actually kind of share my train of thoughts as they happened as Travis told us the story, which was when I heard she presented to the emergency room with the 2 weeks of fatigue and malaise, I was surprised to that. Now, granted, many people use the emergency room because that is their access to medical care. They don't have a primary care doctor or insurance that can help them get seen in a clinic, at least in the United States. But then hearing she recently had a very recent critical diagnosis, it made a lot more sense to me that she had been very sick. And when she started feeling badly again, she went right to the emergency room. That's because, luckily we've heard her TTP has been under control, but TTP is a very grave diagnosis if it's not treated. The thrombotic microangiopathy that happens with the lack of Adams TS13, the small microthrombi that are made, can cause devastating effects on the kidneys, the brain, unless it's treated, which she was. She got steroids to reduce the antibody production as well as the Plex, and then the rituximab also. So it makes sense why she went to the emergency room with these symptoms. I also agree, Abdulaziz, that the fact that her one localizing symptom we heard about here is epigastric pain. I'm not sure if the HPI captured all of it, but correct me if I'm wrong, Travis. She had epigastric pain, but otherwise didn't have nausea, vomiting, or other specific symptoms. I just wanted to clarify that.
You are correct.
Okay. So with epigastric, I think really that's one focus for us to think about in the context of recent critical illness. And it remains pretty nonspecific, right? We've talked before in other episodes about epigastric pain. It can be related to abdominal organs and sort of thinking about what's in the hypogastric area, including the stomach, the pancreas, even biliary problems can refer to there. but it can relate to thoracic problems. And I just want to put on the list, making sure we're not missing cardiopulmonary, specifically angina was one thing that Trada and Zava had chatted about. I would really want to make sure this this woman with, epigastric pain with more history, hearing if it's exertional or not, that we don't miss cardiac ischemia as a unifying category here. I also agree, Abdulaziz. I think the fact that she's gotten quite a bit of immunosuppressive medication recently does make the beginning of a chronic infection something important for us to think about. You mentioned sort of the lack of fevers or night sweats. She's on a fairly large prednisone dose still. We heard 20 milligrams, and that anti-inflammatory effect could completely blunt a fever response. So I think in this case, absence of fever, we shouldn't quickly take to mean absent of infection, given that she's still on high dose prednisone. So I think we're sort of opening categories of pathologies that can cause epigastric discomfort. We talked about GI as well as chest. We're opening pathologies of kind of indolent sort of developing infection. And with her therapies that she's gotten, she's at risk. I'd say particularly most for certainly bacterial infections. That's the number one risk with ongoing steroid therapy, but then some fungal infections as well. And then we hear that she's had an abnormal endocrine disorder history in the past too. She's had Graves with a thyroidectomy on thyroid replacement. We want to make sure that she remains adequately replaced. We talked about many of us had a quick association of fatigue with hypothyroidism. And then finally, she's been on steroids. Correct me if I'm wrong, though. Her dose really is quite high still at 20 milligrams, where results in inadequate, or how shall I say, suppression of her hypothalamic pituitary adrenal axis has probably happened, but she's not at such a point where I would worry her taper has reduced the amount of exogenous steroids to the point where it's unmasked secondary adrenal insufficiency within her. So I think we've got a lot of open categories still with this, but in the context of the TTP, I think it explains why she comes in and she's worried, explains why Abdulaziz rightly is worried about infection. And I hope it's true that the TTP itself remains under good control, but of course, we need to be mindful too when we get labs on her that with reduction of her steroids, she's not actually having a flare of that process again. All right, let's get some more info.
All righty. So this next aliquot, I will go over physical exams and the initial labs. So her temperature was 98 degrees Fahrenheit, heart rate was 80, blood pressure was 149 over 89, respiratory rate was 16, O2 sat was 99% on room air. She generally looked no acute distress. She was well appearing. She had positive conjunctival icterus, not scleral, conjunctival. Her cardiac exam was regular rate, no murmurs, rubs or gallops. There was no peripheral edema. Her lungs were clear, no wheezes or rhonchi. Her abdomen showed some tenderness to palpation in the epigastric region. No hepatosplenomegaly was noted. There was no evidence of any ascites or any other stigmata of liver disease. Her neuroexam, she was alert, oriented, no signs of encephalopathy. There was no asterixis. Her extremities were warm and dry without edema. Now for some labs. CBC, her white count was 12.2. Normal differential was a little bit elevated. Her hemoglobin was 14.1. Her platelet count was 114, slightly low. Basic chemistry panel showed a sodium of 138, potassium 3.6, chloride 106, bicarb was 21, creatinine 0.9, BUN 13, glucose 94. Hepatic function panel showed an ALT of 2,455. AST was 2,460. Alk Phos was 379. Total bili was 12.3. Direct bili was 10.4. Total protein was 5.1. Albumin was 2.8. INR 1.4. PTT was 32 seconds, which is normal. An APAP level was undetectable, and urine drug screen was negative. And that is the end of this aliquot.
Wow. Thanks, Travis. Shweta, there's so much to tackle, right? So let's just like kind of break it up. And first, just the vitals and exam. Any reactions to that as we were first hearing this information?
So I would say the main so in general, this is not a very dramatic exam. So I think that is useful to keep in mind. We were talking before, Steph mentioned that we should not be led astray by the fact that this immunosuppressed patient is afebrile, but it is something to note. Her vitals are otherwise stable other than some mild hypertension, which I'm not inclined to anchor very strongly on. And the epigastric tenderness is in line with the history that we've obtained. I am interested in the conjunctival icterus that was noted. And I actually have not seen this finding before. I've heard of conjunctival paleness with anemia, and I just assume that conjunctival icterus refers to the fact that she has a direct bilirubinemia in her labs, and it just hasn't reached quite the level where you would see scleral icterus, is my understanding, but if that is incorrect, would love some clarification. But based on this physical exam, my concern for a number of things goes down. We were talking about making sure that this fatigue wasn't a manifestation of a cardiopulmonary syndrome, and I don't see any physical exam findings that would suggest that. I don't see any signs of a primary neurologic process or something that would prompt us to jump into emergency immediate treatment mode. So I think we have a little bit more time to figure this out. And that was my impression from the physical exam. So I don't know if we should go into the labs.
Well, wonderful. So yeah, I think Travis, correct me if I'm wrong, but I think what he was emphasizing is actually that the whole term scleral icterus is a misnomer, and that when you have jaundice, the stuff it's actually discoloring the conjunctiva and not necessarily the sclera. So basically the yellow eyes is kind of what you know about, potentially a sign of bilirubinemia, which is what we have here. Is that right, Travis?
Yeah, that's correct. I also, to your point, put in a good review for curious clinicians. They did a whole episode on it, and they kind of go through the history of when it was kind of discovered in 1979. There was a couple ophthalmologists who wrote a letter into a JAMA that was published, and it was titled "Conjunctival Icterus, Not Scleral Icterus," and they go through the reasons why. So we've just been calling it scleral icterus just forever. So.
Okay, awesome. Thank you, Travis. Yeah, and that's really the main thing on this exam, right? And because it points to potentially a liver problem, it might replace the problem representation focusing on fatigue with a problem representation focusing on possible hepatic disease, right? Which we know from the example of PSC, for example, that it can cause very prominent just asthenia and fatigue. So, with the history of TTP, it's when you see jaundice, it's important to think whether it might be mostly indirect hyperbilirubinemia from hemolysis, right? But if the liver was totally normal, you have to be hemolyzing massively in order to have enough bilirubinemia to even discolor the conjunctiva. Usually you don't notice icterus until the bilirubin is about 2 to 3, and generally pure hemolysis with a normal liver rarely causes a bilirubin above 4 or so in isolation. But in this case, again, we can move on to the labs, and we've sort of confirmed that the bilirubinemia is mostly direct, right? So this isn't just hemolysis. Okay, so yeah, let's move on to the labs now, I guess. And share your thinking about sort of both the normals and abnormals here.
Yeah, so looking at the CBC first, we have a little bit of a leukocytosis, which does not remove my concern for infection, given the overall picture of this patient. But also we know that she's on steroids and on a pretty high dose. And so that piece of information is sort of plus minus to me at this point. She also has low platelets, and we don't exactly know where she was living with her TTP, and it's actually a gap in my knowledge of whether in a patient who's being treated for this, we would expect to have some thrombocytopenia for a while after that, but it's not at a level where I would be worried about spontaneous bleeding. In terms of the chemistry, I think I heard that there was an acidosis, but correct me if I'm wrong. And with low bicarb, that would be a metabolic acidosis. And it looks like it would be probably a normal gap, but someone check my math. The really interesting finding here is the dramatic liver function test. So we have—
Hey, Shraddha.
Yeah.
Sorry, just because there's so much, and you've made some really great points and raised some important questions. Let's sort of wrap that up, and before we move into the juiciest, data. So I would, to answer your question about the platelets, they can recover pretty quickly. So generally, when you have TTP and thrombocytopenia, and you duplex, you start steroids, you give FFP, you start give rituximab, whatever, you stop the process, the platelets recover pretty quickly and completely if it's truly under control. So in this case, the fact that the platelets are low again should absolutely raise the question of, has the TTP come back despite the treatments, which it can. So in this case, it would be really important to do a smear and see if there's any schistocytes. The fact that the hemoglobin is normal is already a good starting point. There's not, significant microangiopathic hemolysis, right? An LDH and a retic count would also be helpful, right? If the LDH is normal, okay, even more evidence that there's no active hemolysis, right? If the LDH is 300 and the retics are 10, all right, well, this person just has a really good bone marrow and enough B12 and folate and iron to make new cells, but they are hemolyzing, right? So that would raise concern that, okay, the TTP is back. My overall sense of the picture of these labs is that maybe it's not the TTP, and then the thrombocytopenia should remain an active problem to factor into potentially, be part of the rest of the process that's happening. The only point I want to make on that bicarb of what was it, 21, was it? That you very astutely noted is that, remember that when you just see a low bicarb, you actually don't know whether it's a primary metabolic acidosis when you see a non-GAP, normal GAP bike, or whether it's compensation for respiratory alkalosis, right? And as a good segue into the liver labs, most causes of hepatic dysfunction, whether chronic cirrhosis or acute liver, dysfunction, are associated with a primary respiratory alkalosis, because the liver is what metabolizes progesterone, and progesterone makes you hyperventilate. So it's actually a very common acid-based scenario in patients with liver disease to have primary respiratory alkalosis, hyperventilation, with metabolic compensation, and a slightly decreased bicarbonate with a normal anion gap. All right, liver. Go.
Oh, great. Okay. So I was actually surprised that the liver labs were this dramatic, given that she only had some epigastric tenderness and no evidence of hepatosplenomegaly, but these numbers are really outstanding. So we have, I would call this a mixed pattern of hepatic injury, because we have AST and ALT are elevated, ALT more so than AST, in the low thousands, which makes me think of possible hepatocellular causes of liver injury. And I know that a lot of people were thinking about Hep B reactivation in the context of rituximab. I would imagine that if it were Hep B reactivation, these numbers would actually be higher, but it is something that I'm still thinking about. But there's also a cholestatic picture here, because we have an elevated alk phos, and we have a direct bilirubinemia, as Zavin mentioned. So that, to me, it makes me think, could there be something like an obstructive process, which is like PBC, which has been mentioned previously, which is, causing cholestasis, but is also, because of the magnitude of the obstruction, now also damaging the hepatic cells themselves. So that's another possibility, on top of thinking maybe this is some kind of hepatitis that's happening. We fortunately don't have any sign of a drug effect, although that would definitely be on my list to look into all the meds that she's taking and consider whether there is a direct drug effect that could be causing this picture. And then I think those are all of the abnormalities, but I would love to hear more thoughts about the liver panel, because that's something I'm still working on interpreting.
Well, you've come a long way, because that was a beautiful discussion. Hepatitis B and all hepatitides, they're on the short list of things that can cause massive hepatocellular injury with an ALT in the 4 digits, right? So viral hepatitis, toxins, the most common of which is acetaminophen, that's been ruled out, but other drugs can do it too. And by the way, a quick parenthesis, nitrofurantoin can actually trigger an autoimmune hepatitis-like, syndrome that can do exactly this. And upon re-exposure, it can actually be very fulminant and fatal. Good segue into autoimmune hepatitis, which can happen on its own, or it can be triggered by, sort of a secondary processes. Wilson's disease is classically considered, but in the context of all these other things, obviously less likely here. And that is associated with a low alk phos and a low alk phos to bilirubin ratio. Anyway, we won't get too much into that. And then you mentioned biliary obstruction, which a lot of people don't appreciate, that acute biliary obstruction can absolutely cause, this degree potentially of hepatocellular injury of an ALT, AST this high. Oftentimes, in fact, that's the first, if you occlude your common bile duct, that's the first thing that goes up. The alk phos and bili don't rise yet, but your ALT, AST might spike. And then if the stone passes, they might start to normalize, and your bilirubin, you might not even get jaundiced. On the other hand, if the stone is if it stays stuck, that's when you see more of a, obstructive or mixed picture like this. But by the time you have this duration of symptoms, oftentimes the pain is more prominent, right? Acute sort of biliary obstruction is going to be oftentimes more painful. And after a while, it's going to evolve into cholangitis oftentimes. So not the best picture here, although obviously you have to rule that out with imaging, right? And then saving the most common for last, the most common cause of, really high ALT, AST is ischemic hepatitis. And that can happen on the, most often the arterial side, where there's just hypotension, shock, right? What we call shock liver. We don't really have a good clinical context for that here. But the other way that it can happen is if you occlude the hepatic vein and you obstruct blood flow through the river by blocking its drainage, right? And in the context of having had this diagnosis recently of the TTP, if we assume that everything was by the book, the Adams TS was in a, definitive diagnostically decreased range and the diagnosis was correct, then I don't usually think of macrovascular thrombosis as part of the, clinical features of TTP. It's usually the process is all diffuse and microvascular. But other thrombotic microangiopathies, most notably antiphospholipid syndrome, can cause both microthrombosis and thrombotic microangiopathy, thrombocytopenia, and hemolytic anemia, and a huge risk for macrothrombosis, both venous, atypical venous, like in a visceral circulation, and even arterial thrombosis. So I would just want to go back and make sure that we haven't missed, a different disease entity here that could explain all of these things at once. Going back to the viral hepatitis though, and the question you raised of like, you would expect the levels to be even higher. They can be, okay? But actually viral hepatitis can cause a liver test abnormalities along the entire spectrum from completely normal, especially for chronic hepatitis, to the worst you've ever seen and everything in between. So even if the ALT/AST were like 200, hepatitis B reactivation would still be on the differential. The last point I want to make here is that I would put in a vote for us to take the albumin and the INR and also make them red. Because in this case, we're seeing signs not only of hepatic injury with the ALT/AST, but of hepatic dysfunction, right, with the bilirubinemia, the ability to excrete and conjugate bilirubin, and also to synthesize, clotting factors. So that INR of 1.4 is not normal, and it could be the first sign of evolving liver failure. So we need to trend that very closely. We need to trend her mental status exam and neurologic exam and look for asterisks every time we see her, to make sure that we're not getting to that point where like we need to be, looking for potentially a liver transplant to save her life.
I'm wondering how much more do we have, Travis? Because I'm wondering, should we make a wish list of what we want from here, or whatever you think is best?
So I have some imaging, some additional labs, and then the final thing that led to the diagnosis. So I can do it. I can make this all one aliquot if you would like.
No, let's do it the way it's set up. That sounds great.
Okay. All right. So next aliquot information, we're going to do a little imaging and some additional labs, and I'll leave the last one for our final DX. So an ultrasound was obtained. The gallbladder looked okay. There was no wall thickening. The common duct was normal. The liver appeared normal. The echogenicity was normal. There weren't any hepatic masses or any evidence of cirrhosis. The portal vein was patent and there was appropriate flow. No clots. A CT abdomen was performed that did not show any gallbladder pathology, and there were no significant intrahepatic biliary ductal dilation noted or masses. An MRI abdomen was done, or an MRCP. There was no biliary ductal dilation or filling defects, no cholelithiasis or choledocholithiasis appreciated. And some additional labs. I have an ANA that was negative. A Hep C antibody was non-reactive. A Hep B surface antibody was reactive. A Hep B surface antigen and a hepatitis B core antibody were both non-reactive. Hepatitis A IgM was negative. HIV was non-reactive. Alpha-1 antitrypsin was negative, and an anti-smooth muscle antibody was negative. And that's the last end of this aliquot.
All right, so we've seen the differential diagnosis that Zavan and Sharada have put forward pan out in some of the diagnostics. You want to take us through this, Abdul Aziz, and let us know what you think first of just the imaging findings?
Okay, from the imaging finding about the ultrasound and CT scan, they exclude any biliary obstruction and they exclude any portal vein thrombosis. So Buchiari syndrome is excluded, cholangitis and these are excluded, and even any part of cirrhosis what but is excluded. So it's I think from the lab is the patient have acute liver injury in base of high ALT and AST and low albumin and high INR. I don't know the hepatitis S and this about the imaging. So in the other side, viral screening, is the hepatitis S antigen positive or negative? I don't hear negative. Yeah.
What did you say?
Hepatitis is antigen negative or positive? I don't hear it right.
So the only thing that was positive on was the surface antibody. Everything else was negative.
Okay. So it means we are excluding the most viral infection. So that it is antibody reactive. Anti-smooth muscle antibody is negative. Anti-hepatitis B is negative. HIV is negative. So even autoimmune hepatitis was excluded. So I don't know what is the cause of the severe injury for this liver. Back to the
Thanks, Abdulaziz. Yeah, I think we got pretty comprehensive imaging, really kind of looking for that signs of biliary obstruction, as we heard, that it could explain both the cholestatic and the very high AST/ALT, not there. So we're really kind of working, and nor do we have a apparent perfusion abnormality on the venous side or certainly on the arterial side. So now we're really working with toxin-mediated injury, autoimmune-mediated injury, or viral-mediated injury. The autoimmune mediated injury doesn't seem to be panning out with the negative serologies that she has there. We don't have any clear toxins, so it really makes us think about that viral category with no signs for hepatitis A based on the IgM, at least no prior hepatitis C based on a negative IgG. But a positive hepatitis B surface antibody that we'll have to think about kind of what that means in the past. Remind me, her core antibody was negative also. I guess a question for you, Abdulaziz, the hepatitis B surface antibody itself, just how do you interpret that being positive? And is that still a possibility for her? Way back in the beginning of the story, you actually mentioned hepatitis B as a cause of malaise and epigastric pain. What do you think of that test? And is there anything else we could get to figure out if that is at issue here or not?
Abdulaziz, you might be muted if you're talking, or you are muted.
okay. Yeah. Sorry, I'm mute. You can hear me. Okay. This if the patient take the scenario the patient was have take hepatitis B infection, then it get clearer, and so the patient have hepatitis B antibody with hepatitis B C core antigen IgM. The other scenario, the patient have vaccinated from hepatitis B, so they have only hepatitis B antibody reactive. So I think this patient was vaccinated from hepatitis B, so this only have hepatitis B antibody reactive without hepatitis B C core antigen. This is my idea here.
Yeah, I agree. Really, it sort of fits kind of prior immunity from vaccination as the most likely scenario here. But you guys can correct me if I'm wrong in the chat. Does the hepatitis core antigen, can it wane with prior active infection before, or does it always remain positive? That's an area of uncertainty that maybe others know about, or maybe you know, Abdulaziz.
Really, I don't know if hepatitis core antibody will go with the time.
Yeah,
Don't
I'm not
hear
sure about that either.
about that really.
Is it? Do we? So we usually check an IgM, which might wane, but I know there's also a core IgG.
which should persist, right?
Yes, I haven't heard of sort of.
Yeah, the core. Oh,
The other thing is if the
sorry.
answer is still negative or is negative, I don't know if that's sensitive or if you need a viral load to rule out active circulating disease, but yeah, I think overall I'm with Abdulaziz that it just seems like
Prior immunity.
negative evaluation.
Yeah, I think then the kind of important category to expand on with viral is, are there other viruses that can cause acute liver inflammation like this? Do other viruses come to your mind, Abdulaziz, other than A, B, and C hepatitis?
So other viruses, I don't know, they're like hemorrhagic fever, yellow fever, and other bacteria like leptospirosis. Yeah, this HIV infection was negative, so maybe yellow fever, junk fever. That's
Yeah.
this is my mind now.
Yeah, absolutely. Those definitely have an effect on the liver. And then particularly in someone like her with immunosuppression, also thinking about CMV infection, Epstein-Barr virus infection, and herpes simplex virus infection actually manifesting
Yes.
in the liver. So I think viral is we're not out of viral category at all, even with these basic serologies being negative. And so there could be more evaluation there. And if we were worried at all about the role of the hepatitis C, if it was a core antibody IgM or not, we could get hepatitis B DNA level to put to rest the issue of hepatitis B infection, particularly in the context of the recent rituximab she has. I think that's the connection to know there, that prior hepatitis B infection can be reactivated in the setting of that medication. So I think we want some more viral serologies, expanding the list with what we've come up there. Do you have other wishes, Shraddha or Zavan, before we move forward? Or Abdulaziz, anything else that you guys want to ask Travis for?
So I will request, like so you say, other virus like cytomegalovirus, Epstein-Barr virus, to see if there's any other viral infection we miss it. If it's hepatitis E, and so I think to expand more viral screening.
Great.
Shraddha, anything else?
I had a question. I saw that one of the serologies was negative anti-SM, which I interpreted as anti-Smith. So that isn't for autoimmune hepatitis, as far as I'm aware. So I think that, it is anti-smooth muscle. Never mind.
And you know, I hope I didn't lead anybody astray. When I said that nitrofurantoin can trigger an autoimmune-like hepatitis, I think some of the features are similar on biopsy, for example, but I don't necessarily know whether it's a seropositive autoimmune hepatitis. So I wouldn't take that off the table at all. And speaking of biopsy, actually, my wish list is like, we don't know what's going on. These viral, things might take time and may not be very sensitive or specific. And I think she needs a liver biopsy, actually, because I think the diagnosis is quite time sensitive, and obviously we're talking about a vital organ. So especially before she gets even more coagulopathic and it's an even riskier procedure, I would want to be kind of going in that direction at this point, I think.
All right. What do you have for us, Travis?
So I have a liver biopsy. The liver biopsy, right hepatic lobe, showed diffuse hepatocellular damage, no evidence of autoimmune hepatitis. Portal inflammation grade was 3 out of 4 with lymphohistiocytic infiltrate extending to the portal zone. There were no lobular inflammation or necroinflammatory changes present. And the final diagnosis was drug-induced liver injury, drug-induced hepatitis. So I have a little bit of some teaching pearls and a case resolution for everybody, if you don't mind. So the final diagnosis was made drug-induced liver injury, otherwise known as DILI, which I think is one of my favorite names for a disease. while the other causes were ruled out. DILI was suspected because of the atovaquone, I guess has been documented as it given the time, the initiation of the drug and the disease onset. The patient never experienced acute liver failure, no hepatic encephalopathy. Her INR never was elevated greater than 1.5. Unfortunately, after the biopsy, she developed a hepatic hematoma, which kind of prolonged her hospitalization and recovery. But 2 weeks after drug cessation, her liver enzymes and bilirubin started to improve. And at follow-up several weeks later, the values continued to downtrend. So DILI has an estimated annual incidence between 10 and 15 per 10 to 100,000 persons, and is the cause of 10% of acute liver injury cases. There's been over 10,000 medications that have been linked to DILI, which I will put a website link on here that we are going to require everybody to memorize each of them afterwards. It's the characterization of DILI can include the clinical pattern of liver injury, which is hepatocellular injury where aminotransferases elevation is disproportionately higher than the rise of ALK-Phos. A cholestatic injury where ALK-Phos elevation is disproportionately higher than aminotransferases. And then there's a third category, a mixed pattern. And there's an R factor on MD-Calc that you can use, and you can kind of plug in the ranges, so it can kind of give you kind of what pathway to take when you're making your differential. So furthermore, liver injury can be characterized by histologic evaluation or by the mechanism of injury. Was the injury from the suspect drug? Was it idiosyncratic, or was it predictable, like a Tylenol overdose? One of the big things in the case, anytime you're getting, liver injury is checking for, Tylenol, trust but verify. Sometimes people, say they haven't taken something, but, it's always good to check. Liver injury secondary to atovaquone is very rare, and there's only a handful of cases. In one of the published cases, a patient developed cholestatic liver injury after starting atovaquone for PJP prophylaxis with normalization of liver enzymes and bilirubin after 12 weeks of drug cessation. And that's about it. I got one other clinical pearl here, just going back on the R value, which defines the type of liver injury. So hepatocellular DILI is defined as an R greater than 5. Cholestatic is R less than 2, and mixed is between 2 and 5. And liver biopsy is usually done if the diagnosis remains uncertain. And that's it. So awesome discussion.
Lovely case. Thank you so much, Travis. Thank you, Franco, for taking notes for us. And Shraddha and Abdulaziz, had a really fun on a journey with y'all. A really fun time. And thank you so much for engaging. Thanks everybody for joining.
Have a great day.